Here I'm going to discuss the function of different cranial nerves in innervation of the extraocular muscles, and then after that discuss the pupillary reflex and how we can determine whether it's the afferent nerves that are being defective in the pupillary reflex or whether it's the afferent nerves that are defective. Now, starting with the extraocular muscles, we have 6 different extraocular muscles: inferior rectus, lateral rectus, superior rectus, medial rectus, which are moving eye in the directions the arrow is showing, and then the inferior oblique, which causes extorsion of the eye, and then the superior oblique, which causes intorsion of the eye. Now, in order to determine which of these muscles is defective, here is a drawing that will show you which direction the patient is supposed to look at. So if the patient cannot look medially, then the medial rectus is not working. If he or she cannot look laterally, then it's the lateral rectus that is not working. Now, if the eye is in the abducted position and the patient cannot look down, then it's the inferior rectus that is not working. And if again in the abducted position the patient cannot look up, it's the superior rectus that is not working. On the other hand, if the eye is in the adducted position and cannot look down, it's the superior oblique that is not working. And then if in adducted position cannot look up, it's the inferior oblique that is not working. Now, with the medial rectus, lateral rectus, inferior rectus, and superior rectus, the names already tell you which direction the eye is supposed to look at. So it's only the superior oblique and inferior oblique that's kind of make it confusing. And so here I have provided you with a memory aid that will make you never forget where you're supposed to look at with the superior oblique. So the nose is so soft. So the superior obliques are all closest to the nose. So now you know that the superior oblique, you should always consider having the eye look in the adducted position and look down to test for the superior oblique. And then the inferior oblique is on the opposite side. Now, moving on to different cranial nerves that innervate the extraocular muscles. So we have 3 different cranial nerves that are innervating the extraocular muscles: the cranial nerve 3 or oculomotor, cranial nerve 4 or trochlear, and cranial nerve 6 or the abducens nerve. Now, cranial nerve 4 is innervating the superior oblique, and cranial nerve 6 is innervating the lateral rectus. And in order for you to remember which of these muscles are innervated by these nerves, I have a memory aid for you called L6SO4. So you may recall from chemistry that we had the chemical formula H2SO4. Now forget about that and memorize this new formula, L6SO4. So cranial nerve 6 is innervating the lateral rectus, while cranial nerve 4 is innervating the superior oblique. And then the rest of the extraocular muscles are innervated by cranial nerve 3. So if we go back here, the lateral rectus, so we had L6SO4, so the lateral rectus is innervated by cranial nerve 6, the superior oblique is innervated by cranial nerve 4, and then the rest of these muscles are all innervated by cranial nerve 3. Now, in addition to these 4 muscles, cranial nerve 3 is also innervating the levator palpebrae superioris, which is required for opening the eyelid. It also innervates the sphincter pupillae, which is required for constriction of the pupil. And then finally, it innervates the ciliary muscle, which is required for accommodation. So now you can see that if there is a lesion of cranial nerve 3, if the levator palpebrae superioris is not working, there would be a droopy eyelid or ptosis. Lesion of cranial nerve 3 will also interfere with the sphincter pupillae, so therefore there would be dilation of the pupil or mydriasis. And since there would be interference with the function of the ciliary muscle, there would be loss of accommodation, and thus the patient will have a blurry vision. So now with that information in mind, let's review the feature of the oculomotor palsy. So in this example, the patient has a cranial nerve 3 lesion. So this right eye has a cranial nerve 3 lesion. So first there would be ptosis of the eyelid, so the eyelid would be droopy, and here you can see that the investigator is holding the eyelid up with the thumb, and this is due to the loss of the function of the levator palpebrae superioris muscle. There would be dilation of the pupil because there is loss of the function of the sphincter pupillae. And now since the other 2 muscles, which is the lateral rectus and superior oblique are taking over. So since none of the muscles that are innervated by cranial 3 are working, these two will take over. And so the function of lateral rectus is to look laterally. So the eye will look laterally or out. And then the function of superior oblique, the memory aid for that is saw lid. So the function of superior oblique is to look laterally. It causes intorsion of the eye, and then it causes the eye to look downward. So therefore, superior oblique also enhances the eye to look laterally. In addition, it will look downward. So therefore, that's the features of the oculomotor palsy, where the patient will have ptosis, dilation of the pupil, and then the eye will look out and downward. Now, once you go to an ophthalmologist or an optometrist, there are two different drops that they put into your eye, and those are for dilation of your pupil. Now here I would like to review the mechanism of those drops with you. So phenylephrine is a sympathomimetic that will activate the alpha adrenergic receptors that will function to activate the dilator pupillae muscle, as a consequence of which now there would be mydriasis or dilation of the pupil. Tropicamide, on the other hand, is an antimuscarinic which will inhibit the function of the parasympathetic nerves, as a consequence of which the sphincter pupillae no longer functions, so the patient will develop mydriasis, and then the ciliary muscle would not function, and so the patient will develop cycloplegia or loss of accommodation, as a consequence of which there would be a blurry vision. And so if you recall, both of these muscles are innervated by the parasympathetic branch of the cranial nerve 3. So now, if ophthalmologist or optometrist only puts phenylephrine into your eyes, you will have dilated eyes, and so the light will bother you. But then if they put tropicamide in your eye, in addition to having dilated eye, you will also have cycloplegia, which causes blurry vision for a few hours. Alright, now moving on to the pupillary reflex. So here I have shown you the pathway that will tell you how, by shining light into one eye, both pupils will be constricted. So here, for instance, if you shine light into the left eye, what happens is that the retina will perceive the light, and via the optic nerve or cranial nerve 2, it will send signals to the bilateral pretectal nuclei. And then pretectal nuclei will activate bilateral Edinger-Westphal nuclei, and Edinger-Westphal nuclei via cranial nerve 3 or oculomotor nerve send signals to the ciliary ganglion, which activates the postganglionic parasympathetic nerves to function on the pupillary sphincter and cause constriction of pupil. Now, exact same pathway exists on the other side. So the pretectal nuclei will be activated here, and so it will function on the Edinger-Westphal and then send signals to the pupillary sphincter. So by shining light into one eye, therefore both pupils will be constricted, because both bilateral pretectal nuclei and bilateral Edinger-Westphal nuclei are activated. So let me summarize the findings. You shine light into the retina via cranial nerve 2 or the optic nerve, signals will be sent to the bilateral pretectal nuclei, which will activate the Edinger-Westphal nuclei, and then Edinger-Westphal via cranial nerve 3 sends signals to the ciliary ganglion, and then ciliary ganglion via the post-ganglionic parasympathetic nerves will activate the pupillary sphincter to cause miosis of the pupil. Alright, now with that information in mind, let's review how the function of the pupil constriction will be affected with lesion of the right optic nerve. So here in this example, the right optic nerve or cranial nerve 2 is dysfunctional. And the question is, how would the pupil respond to the light if we shine light into the left eye in this example, for instance? So if we shine light, what happens is that cranial nerve 2 in left eye is intact. So it will send signals to bilateral pretectal nuclei, which will activate bilateral Edinger-Westphal nuclei, and now Edinger-Westphal via the cranial nerve 3 send signals to both pupils, as a consequence of which we will have constriction of both pupils. On the other hand, if we shine light in the right eye, since the cranial nerve 2 is not working, so basically this eye is blind, so nothing, no signal will pass through, and therefore neither Edinger-Westphal nuclei will be activated, and so therefore neither pupils will be constricted. And so here was an example of having a defective afferent limb of the pupillary reflex. So afferent limb is by the cranial nerve 2, which receives the signals, and then afferent is via cranial nerve 3, which causes the pupil constriction. So here is a summary of what I just told you again. The optic nerve is the one that is receiving the signals, and then so it's the afferent limb, while the oculomotor is the one that is sending signals for constricting the pupil. So this is the afferent limb. So if the cranial nerve 2 in the right eye is not working, if we shine light in the left eye, still everything will be activated, and so both pupils will be constricted. But if we shine light in the right eye, no signals will pass through, so neither pupils will be constricted. Alright? Now there could be another scenario where the afferent limb of the pupillary reflex, which is the oculomotor or cranial nerve 3, is not working. So in this example, let's assume that the right cranial nerve 3 is not working. So what would happen to the pupil constriction reflex if we shine light in the left eye? So what happens here is that the optic nerve will send signals to the pretectal nuclei, which will activate the bilateral Edinger-Westphal nuclei. And then Edinger-Westphal via the cranial nerve 3 will activate the sphincter pupillae. So the left cranial nerve 3 is working, so signals will pass through here on the left side. But the right cranial nerve 3 we just discussed is dysfunctional. So therefore there won't be any constriction of a right pupil. So in this scenario you will only get constriction of a left pupil but not the right pupil. Alternatively, if you shine light in the right eye, what happens is that optic nerve will send signals again to the pretectal nuclei, which will send signals to the bilateral Edinger-Westphal, and now cranial nerve 3 will be sent out to both eyes. Now the left cranial nerve 3 is functional, so you do get constriction of the left eye, while the right cranial nerve 3 is not working, so you do not get constriction of the pupil on the right side. And so again, the findings are similar to the other condition that I just described there. So only the left eye will have constriction, but not the right eye. And so here you can see how the pupillary reflex would be different, whether it's the afferent limb or the efferent limb of the pupillary reflex that is defective. And that concludes our discussion of the extraocular muscles of the eye, their function, their innervation, the oculomotor palsy, as well as the pupillary reflex pathway.